Welcome to 7 Minute Surgery. Today we will discuss shock, a common and critical medical emergency. We aim to define shock, classify its types, focus on its pathophysiology, identify its signs, and outline the treatment goals. First, let's define shock. While many definitions exist, all imply reduced tissue perfusion. Shock is defined as a life-threatening condition of acute circulatory failure. Shock is a pathophysiological status rather than a diagnosis. Now let's analyze the different patterns of shock. Shock represents a circulatory failure, so let's revisit the circulatory system. Here is the heart, the capillary bed, the venous return, and the cardiac output. A reduction in intravascular volume precipitates hypovolemic shock. This can be due to trauma, gastrointestinal bleeding, bowel obstruction, pancreatitis, and burns. Impedance on the venous return leads to obstructive type of shock due to tension pneumothorax, cardiac tamponade, or pulmonary embolism. In cardiogenic shock, the valve is directly affected either by myocardial infarction, arrhythmias, or other causes, while peripheral vasodilation results in distributive type of shock as in septic shock, neurogenic, and anaphylactic shock. Now, let's untangle the complex pathophysiology. So, when the intravascular volume is reduced, the baroreceptors are activated. These are present in the carotid sinus and the aortic arch. The baroreceptors will act on the adrenal glands to secrete epinephrine and norepinephrine. These two act on the heart to increase the cardiac rate and contractility, and on the peripheral circulation to increase the peripheral vascular resistance. These physiological responses try to compensate for the reduced blood pressure. At the same time, the baroreceptors act on the posterior pituitary, so the posterior pituitary secretes ADH, which acts on the kidneys to activate the renin, angiotensin, aldosterone system, which leads to sodium and water retention in a trial to preserve the intravascular volume. If these compensatory mechanisms are successful, then we have a compensated type of shock with a preserved blood pressure, and this condition is highly reversible. You can see in the monitor there is tachycardia, tachypnea, but the blood pressure is still maintained. However, if there is a delay in the recognition or treatment of shock, it will evolve into decompensated type with eventual hypotension. Oxygen is vital for cellular metabolism and integrity of the vascular endothelium. Oxygen deprivation in shock drives a shift to anaerobic metabolism, causing lactic acid accumulation. Failure of ATP-dependent pumps causes intercellular fluid shift and swelling, and the cells will eventually rupture, releasing damage-associated molecular proteins. Hypoxia induced endothelial injury triggers vascular permeability, microvascular thrombosis, and dysfunction. Additionally, in septic shock, there is release of pathogen-associated molecular patterns by the causative microorganisms. These together stimulate an inflammatory response by the body, resulting in the release of this set of inflammatory mediators, and a vicious circle is established. When perfusion to vital organs is impaired, cell death occurs, followed by organ dysfunction, multiple organ dysfunction, and mortality. This is a time-dependent process, so keep in mind this countdown timer for the development of organ dysfunction. It is crucial to clinically recognize shock before the decompensation stage and hypotension. First, we need to understand the context. Are we dealing with a trauma, gastrointestinal bleeding, or burn patient? In these cases, we are expecting hypovolemic shock. The hemodynamic status of the patient is a product of insult severity, physiological reserve, and the time lapse. To recognize shock, we need to assess the mental status vital signs, skin temperature, capillary refill, and urine output. These include measures of perfusion to the brain, the skin, and the kidneys. Now we move on to the management of shock. We need to start resuscitation immediately with the ABCDE approach. To intubate if the Glasgow coma scale is 8 or less, give oxygen if needed according to the saturation, establish wide bone cannula and give intravenous fluid 500 ml as a bolus. Patient with hemorrhagic shock unresponsive to IV fluids will need blood products. Targets of resuscitation are mean arterial pressure of 65 mm of mercury, adequate for perfusion of vital organs, and a urine output of 0.5 ml per kg per hour. We take a short focus history during resuscitation, and a detailed history and thorough clinical examination are performed after resuscitation. Laboratory tests differ according to the underlying cause, but in general they include CBC, glucose, urea electrolytes, lactate, ABG. Imaging tests are requested according to the possible underlying etiology. In case of trauma, we have the chest X-ray, the pelvic X-ray, and the focused abdominal sonography for trauma. Now, according to the underlying etiology, a specific treatment is needed. For example, hypovolemic shock due to pelvic fracture is treated specifically with pelvic binder or pelvic wrap, fixation, and in some cases, operative packing. In case of tension pneumothorax, an immediate needle decompression is needed and a chest tube needs to be inserted. To sum up, shock is an acute circulatory failure. Its pathophysiology dictates the interventions. Early clinical recognition and treatment are crucial. Hypotension is a late sign. Delay means organ dysfunction. Thanks and see you soon.